Sir, please, 3, 2, 1, start.
Good morning, everybody. So once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a teaching class on testicular tumors. And this will be presented by our resident, Dr. Prashasya Gòyal, and it will be moderated by our faculty, Dr. Somendra Bansal. So I request Dr. Somendra Bansal to kindly ask Dr. Somendra to start the presentation.
A very good morning, all of you. Today, in continuation of our academic program, there is a seminar on the testicular tumor, which will be presented by Dr. Prashasya Gòyal. Now I invite Dr. Prashasya to start his presentation. Dr. Prashasya.
Good morning, everyone. My topic for seminar today is testicular tumors. Testicular tumors are basically can be categorized as the one with the germ cell tumors, or the one with the originating from the non-germ cell tumors. Germ cell tumors, most of them, 95% of them. Just a second. Cool. 95% of them occur in testes, while 5% of them are extragonadal. Epidemiologically, they occur commonly between 15 to 55 years of age group, and they peak at 25 to 35 years. They are the most common malignancies in males between.
Your slide is not moving.
Okay, sir. Just. As I was saying, epidemiologically, these germ cell tumors are most common between the age group of 15 to 55 years, and they
change the slide. Change the slide.
Sir, can you just see?
No, we are not able. You are see the first slide. We are able to see the first slide.
There's no slide.
Yes, we can see. Yes, go ahead.
Yes, sir. Sir, epidemiologically, they occur most commonly between age of 15 to 55 years, and they peak at 25 to 35 years. And they are the most common malignancies in men between the age of 20 to 40 years. They are bilateral in 2%. Mostly, they are metachronically bilateral, and they can have discordant histology in 30 to 50% of patients. Risk factors for developing a germ cell neoplasm is white race, history of CA testes in the patient itself, the family history. The risk is greater when the brother has a positive history of CA testes as compared to father. And the history of cryptorchidism, the risk of CA testes in the same testes is as a relative risk of 4 to 6, while the risk in contralateral testes is also slightly higher, 1.74. And then there is germ cell neoplasia, germ cell ITGCN or GCNIS, which is considered to be the precursor of most GCTs except prepubertal spermatocytic seminomas, dermoids, and teratoma. In patients with history of GCT, the presence of microlithiasis as seen on USG determines an increased risk of GCNIS. However, the presence of GCNIS in an otherwise orchidectomy specimen has no prognostic significance. Also, diet and environmental factors play a major role in the development of germ cell neoplasm. Pathologically, these neoplasms GCNIS arise from primordial germ cells which fail to progress into spermatogenesis. Also, there is an increase in copies of short arm of chromosome 12 in post-pubertal GCTs except spermatocytic. Extragonadal GCTs are relatively less common, which are most 5% pubertal. Most of them arise in the midline, either in the retroperitoneum or the mediastinal. An important thing about the primary mediastinal non-seminomatous germ cell tumors is that they are less sensitive to chemotherapy, have poor prognosis, and more likely to have a yolk sac component. And they are also more commonly associated with Klinefelter syndromes and hematological malignancies. Primary mediastinal seminomas and behave similar to testicular tumors. The incidence among the germ cells tumors can be divided into two categories broadly: seminomas, which have an incidence of 50 to 56%, and non-seminomatous germ cell tumors, which have an incidence of 44 to 48%. Seminoma, which is the most common subtype of a germ cell tumors, most commonly occurs between 4th to 5th decade. It has a soft tan to white diffuse or a multinodular mass. And on histopathological examination, it consists of a sheet-like arrangement of cells with a polygonal nuclei and clear cytoplasm. Although seminomas do not excrete beta HCG, but in 15% of cases, syncytial trophoblast can be present, and thus in 15% of seminoma, beta HCG can be raised. These tumors are negative for CD30 and are positive for CD17 and are strongly positive for placental alkaline phosphatase. Seminomas are also considered to be the common precursors of other non-seminomatous tumors. In non-seminomatous tumors, then there is spermatocytic tumors. It was earlier considered to be a subtype of a seminomatous tumor, but now it has been classified separately. The peak incidence occurs in the 6th decade of life. It is different from other germ cell tumors in the sense that it does not arise from the germ cell GCNIS. It is not associated with cryptorchidism, or it does not occur bilaterally. It does not increase copies of short arm of 12 chromosome, and it does not occur as a part of mixed GCTs. These are basically, they also do not stain positive for OCT3, placental alkaline phosphatase, or glycogen. These spermatocytic tumors are basically benign and almost always cured with orchidectomy. However, spermatocytic tumors associated with sarcoidosis can have a risk of malignant potential. Then there is embryonal carcinoma, which is considered as the most undifferentiated malignancy. Grossly, it is tan to yellow, and histopathologically, it exhibits large areas of hemorrhage and necrosis. It is consists of syncytial trophoblast can be identified, and it has the totipotency to differentiate into other types of non-seminomatous tumors, including teratoma, either within the primary or at the metastatic sites. It stains positive for placental alkaline phosphatase OCT304, but however, it do not stain positive for c-KIT. Choriocarcinoma is another subtype. It has a poor risk at diagnosis because it can of the serum beta HCG level and a non-pulmonary organ metastasis, most commonly to the brain. It is one of the malignancies that spread, testicular malignancies that spread primarily by hematogenous routes. It is composed of syncytial trophoblast and cytotrophoblast, and the former stains positive for HCG. This malignancy is prone to hemorrhage either at the primary or at the site of metastasis. That can occur either spontaneously or after chemotherapy. And such bleeding, especially at the metastatic sites like brain, can be catastrophic. It is also associated with other hormonal disturbances such as hyperthyroidism, elevated androgen production, and hyperprolactinemia, because these beta HCG can cross-react with thyroid receptors. So, yolk tumors present a very small fraction of adult tumors. However, they are more common in mediastinal and pediatric age group. They show a glandular, papillary, or microcystic pattern, and they have a characteristic Schiller dual body that's present in 50% of cases. And eosinophilic hyaline globules are another characteristic histological feature which is present in 84% of cases. Yolk sac tumors almost always produce alpha-fetoprotein, but they never produce HCG. Teratomas are considered another subtype which originate from at least 2 of the 3 germ cells layers among the endoderm, mesoderm, or the ectoderm. However, they are classified as mature teratomas and immature teratomas. However, there is no clinical significance to that. They are usually associated with normal serum tumor markers, but they sometimes can cause mildly elevated serum alpha-fetoprotein levels. An important thing is that teratomas are resistant to chemotherapy, so surgery remains a mainstay of treatment for such tumors. They can grow uncontrollably, invade the surrounding cell structures, and easily become unresectable. Teratomas also have the capacity to transform into somatic malignancies like rhabdomyosarcoma, adenocarcinoma, etc. Talking about the clinical features, testicular tumors most commonly present as painless testicular mass. Among the symptoms, pain is the most common symptom which is present mostly in non-seminomatous tumors, which is due to hemorrhage or infarction. Regional metastasis can occur in up to 2/3 patients of non-seminomatous tumors and 15% seminomas on presentation. 2/3 of patients with testicular tumors have infertility, but it is rarely a cause of initial presentation. For diagnosis, the first line of diagnosis is a scrotal USG, which is considered an extension of our physical examination. Germ cell tumors are typically hypoechoic, and among them, the non-seminomatous are heterogeneous, while seminoma is seen as homogeneous hypoechoic structure. The presence of tumor in a contralateral testis is 2% metachronously, and synchronously it is only 0.5%. Presence of a less than 1 centimeter impalpable lesion in testes without any evidence of dissemination or a raised tumor markers points toward a relatively benign disease such as cyst or infarct. Another situation is when there evidence of an advanced GCT such as raised tumor markers or presence of lymphadenopathy in the body with normal testes. In most of these cases, this is associated with a burnt out primary, which is most common in seminoma. It is indicated by a coarse scar or calcification in the testes. And these patients should undergo radical orchidectomy due to the presence of a residual teratoma or a GCNIs. In rest 1/3 cases, one should look for a presence of an extragonadal germ cell tumor. Among the evaluation of patient, the first is the tumor markers. It should be done at the time of diagnosis, post orchidectomy level, post chemotherapy, and for surveillance after the therapy continues. The tumor markers that are important are mostly three: alpha fetoprotein, beta HCG, and LDH. Alpha fetoproteins are raised in embryonal cell carcinoma and yolk sac tumors. They have a half-life of 5 to 7 days, and they can also be raised in a hepatocellular carcinoma, biliary malignancy, or CS tumor. Beta HCG is raised in embryonal cell carcinoma and choriocarcinoma, and 15% of seminomas. They have a half-life of 24 to 36 hours. They are also raised in CA breast, kidney, or lung. Beta HCG can cross-react with luteinizing hormone, and there can be false positive. This can result in a false positive in patients with hypogonadism. So patients with hypogonadism should be treated with testosterone, and then later a beta HCG should be repeated. LDH is a non-specific marker, and it indicates the bulk of disease. The half-life of LDH is 24 hours. Further evaluating the patient, CCT abdomen should be done in all patients of testicular masses. A false negative rate increases if 1 centimeter is used as a cutoff for identifying a lymph node. However, lymph nodes of 5 to 9 millimeters in the primary landing zone should be considered in suspicion in a patient of testicular mass. Primary landing zones for the mass on the right testes are interaortocaval, paracaval, para-aortic, and for left it is interaortocaval and para-aortic. There can be caudal deposits in the iliac and inguinal lymph nodes, which are suggestive of a retrograde and a high volume disease, and very rarely an aberrant lymphatic drainage. Chest and the evaluation of chest, all patients should undergo chest X-ray. Thoracic mats in absence of retroperitoneal lymphadenopathy or raised tumor markers are uncommon. CCT chest is indicated if there are elevated post-orchidectomy levels of serum tumor markers, the presence of retroperitoneal lymph node disease, abnormal findings on chest X-ray, or a clinical stage 1 non-seminomatous tumor with lymphovascular invasion or embryonal cell carcinoma predominates. CT brain is indicated mostly in choriocarcinomas if the HCG levels are greater than 10,000. There is a IgCG risk group for metastatic germ cell tumors. It classifies these germ cell tumors into good prognosis, intermediate prognosis, and poor prognosis. However, the seminomas only have good prognosis or intermediate prognosis. The good prognosis includes where the serum tumor markers are in non-seminoma includes that there are no non-pulmonary visceral metastasis, and the markers are low. They are associated with a 5-year progression-free survival of 89% and an overall 5-year survival of 92%. For seminomas, a good prognosis is indicated by that seminoma can be present at any primary site and should have a no non-pulmonary visceral metastasis and normal level of tumor markers. For intermediate prognosis, in non-seminomatous tumor, it should have a testicular or retroperitoneal primary with no non-pulmonary visceral metastasis, and an intermediate marker with AFP between 1,000 to 10,000, HCG between 5,000 to 50,000, or LDH greater than 1.5 times the normal or less than 10 times the normal. They have a 5-year survival of 80% with a 5-year progression-free survival of 75%. Intermediate prognosis for seminomas are any primary sites with non-pulmonary visceral mets and a normal AFP. Poor prognosis for patients with non-seminomatous tumor include a mediastinal primary or the presence of a non-pulmonary visceral metastasis, or poor serum markers such as AFP greater than 10,000 or beta HCG levels more than 50,000 and LDH levels greater than 10 times the normal limit. They have a 5-year survival of only 48%. Regarding the management, the radical inguinal orchidectomy is the first step and should be performed within 1 to 2 weeks of diagnosis. In a mixed non-seminomatous tumor, the percentage of each component should be reported. A transscrotal orchidectomy or biopsy is contraindicated because number one, it alters the lymphatic drainage. It increases the risk of local recurrence, and it increases the risk of pelvic and inguinal lymph node metastasis. Another option is the testis sparing surgery. It is completely contraindicated if the patient has a normal contralateral testes. The indication for a testis sparing surgery is that if the disease is small, 2 to 3 centimeter, and occupies less than 30% of the testes, with the presence of a synchronous bilateral tumor, or in the presence of a solitary testes, or if a benign pathology is suspected. Sperm cryopreservation is another factor. The 52% of patients of testicular mass are oligospermic and 10% are azoospermic. Post chemotherapy, almost all patients become azoospermic, and it takes 2 to 5 years for levels to return to pre-chemo levels. Even after post radiotherapy, it takes 2 to 3 years for sperm to return to pre-radiotherapy levels. So sperm cryopreservations should be advised to every patient with a testicular mass. Staging of the primary tumor is when it cannot be assessed. PT0 is no evidence of primary tumor. PTI is intratubular germ cell neoplasia. T1 is when it is limited to the testes and epidermis without invasion of the vessels or the lymphatics. However, it may invade into the tunica albuginea but not into the vaginalis. PT2 is when the tumor is limited to the testes and epidermis with invasion of the vascular or the lymphatic system, or the tumor extending through the tunica albuginea with involvement of the tunica vaginalis. PT3 is where it involves the spermatic cord, and T4 is where it involves the scrotum. Regional lymph nodes are NX when it cannot be assessed, N0 is where there is no metastasis, N1 is when the lymph node mass is less than 2 centimeter in the greatest dimension, or if there are multiple lymph nodes with none greater than 2 centimeter. N2 is when the lymph node mass is between 2 to 5 centimeter in the greatest dimension, or multiple lymph node, all of them are between 2 to 5 centimeter. And N3 is when the lymph node mass is greater than 5 centimeter in greatest dimension. Metastasis is M0, no metastasis. M1A is non-regional nodal or a pulmonary metastasis, or M1B is distant metastasis at anywhere else. Serum tumor markers, CA testis is characterized by serum tumor markers which are used in its staging. Serum S1 is when LDH level are less than 1.5, the normal limits, or HCG levels are less than 5,000, and AFP levels are less than 1,000. Serum S2 is when the LDH level are between 1.5 to 10 times the normal limit, and AFP levels are between 5,000 to 50,000, and HCG level are between 5,000 to 50,000, and AFP levels are between 1,000 to 10,000. And S3 is when LDH is greater than 10 times the normal, HCG is greater than 50,000, and AFP levels are greater than 10,000. This is the stage grouping of the for CA testing. Stage 1 is defined by when there is no nodal disease. Grossly, it is no nodal disease. Stage 1S is a separate category. When there are no nodal disease, there can be any pathological tumor, but only the serum tumor markers are raised, which can raised from S1 to S3. However, there is no nodal disease and there is no metastasis. Stage 2 is characterized by any local PT stages, can be anything, but it is characterized by a nodal disease. And 2B is considered, up till 2B, it is considered to be early, where the nodal stage is N2. And from 2C, it is considered as an advanced disease when the nodal stage becomes N3. Stage 3 is characterized by metastasis. And now management of retroperitoneal lymphadenopathy is very important for CA testes. Here are a few general facts. This retroperitoneal lymph nodes are positive in 5% of clinical stage 1 tumors and 10% of clinical stage 2 tumors and 85% clinical stage 3 tumors in seminoma, while there can be they have an equal incidence of retroperitoneal lymphadenopathy in a non-seminomatous tumors. Occult metastasis in clinical stage 1 can occur in 10 to 15% of patients with seminoma and of about 20 to 25% patients of non-seminoma. Relapse rates are 1 to 4% after radiotherapy in seminoma and 10% after retroperitoneal lymph node dissection. For management of a management of clinical stage 1 of a non-seminomatous tumor, in pathology, we have to look for two factors: the presence of lymphovascular invasion and a predominant embryonal cell carcinoma component if it is greater than 45%. These are risk factors for presence of occult metastasis. In the absence of these two risk factors, the risk of relapse is less than 20%. There are three modalities to manage a clinical stage 1 non-seminomatous tumors. That is surveillance, either chemotherapy or a retroperitoneal lymph node dissection. All of them have an overall survival rate of 100%. For clinical stage 1S patient in which there are no nodal or distant metastasis, but they have raised serum tumor markers, these should be treated as we will see later for class 2C and 3 patients. Among the three modalities, surveillance, it has the advantage that of only 70 to 80% of clinical stage 1 patients need 70 to 80% patients of clinical stage 1 need orchidectomy alone. And if there is a relapse, it can be treated with chemotherapy. However, also it avoids the toxicity of an unnecessary treatment. However, if there is a higher risk of relapse among all the modalities, that is 28%, and 90% of these relapses occur within 2 years. Most of these relapses, about 65%, occur in retroperitoneum. And these relapses can be either treated with chemotherapy or they can be treated with retroperitoneal lymph node dissections. Retroperitoneal dissection has the advantage that since the retroperitoneum is the most common site of occult metastasis, after an RPLND, the relapse rates are very low, 1 to 2%, and it avoids chemotherapy in 75% of a patient. Even if there is a relapse, there is a high salvage rate if a patient is given chemotherapy, avoids the toxicity of chemotherapy, and it is curative in patients 60 to 90% of N1 disease and N1 to N3 disease with pure teratoma. The disadvantage of a retroperitoneal lymph node dissection is that it can be performed only at expert centers. For chemotherapy, usually a combination of BEP1 is usually given. It has the advantage of having the lowest risk of relapse with a single modality, and it avoids surgical morbidity. The disadvantage is that if relapse occurs, it is usually chemoresistant. The management of clinical stage 2A or 2B disease are, we have two options. Either we can undergo a primary retroperitoneal lymph node dissection followed plus minus chemotherapy, or an induction chemotherapy, which can either be followed by retroperitoneal lymph node dissection or not. Overall survival rate for these class of patients is 98 to 100%. Retroperitoneal lymph node dissections has the advantage that 30% have retroperitoneal teratomas, which are not responsive to chemotherapy. And around 30 to 35% have false negative nodes, and thus these patients avoid a chemotherapy. Disadvantage is an additional 48% require an additional chemotherapy, and it can be performed only at expert centers. The advantage of an induction chemotherapy is that in 60 to 78%, there is full remission, and thus the patient avoids surgery. However, the patient has to tolerate the toxicity, and there is a surveillance with CT that has to be done, which can increase the risk of secondary malignant neoplasm. And the most important is that induction chemotherapy does not treat teratoma in the retroperitoneum. The conclusion among these is that if the patient have a raised serum tumor markers and a lymph node mass of greater than 3 centimeter, induction chemotherapy should be given. And the patient, if the patient has an increased risk of teratoma, such that the primary malignancy is a teratoma with normal serum tumor markers, and the lymph node mass is less than 3 centimeter, retroperitoneal lymph node dissection should be given. For patients of class 2C and 3, that can be of good risk. A BEP3 or a EP4 patient can be given with an overall survival rate of 91 to 94%. And for patients with intermediate or poor risk, BP4 is the first choice. However, in patients with compromised pulmonary function, bleomycin can be omitted, and a VIP chemotherapy, 4 cycles of VIP chemotherapy can be given. Assessment of a post-chemotherapy residual masses is done by a CT abdomen and pelvis. They can be classified into 3 categories. There are complete responders, which have resolution of the radiographic disease with normal serum tumor markers. They can either be observed, or they can undergo a post-chemotherapy surgery if a pre-chemo mass was greater than 3 centimeter. The second category is partial remission, in which there is decrease in size of the retroperitoneal mass with normal serum tumor markers. The management is usually post-chemotherapy surgery, as there is a 15% risk of malignancy in the mass and a 45% risk of teratomas in the mass. In patients with partial remission with raised serum tumor markers, or the patients with progression should undergo a salvage chemotherapy. And if the residual disease is still present, the patient should go under surgery. There is no role of evaluation of a post-chemotherapy mass in non-seminomatous tumors with FDG scan, because teratomas are present in large numbers and they are not FDG avid. The complete removal of a retroperitoneal disease is the most important prognostic factors in such patients. Talking about relapse in a non-seminomatous tumors, it can be also classified into 3 categories. It can be occur in a chemo-naive patient, number one, who was under surveillance. Such patients should go retroperitoneal lymph node dissection if the mass is less than 3 centimeter or a normal serum tumor markers. Otherwise, our induction chemotherapy should be given. If a patient is chemo-naive after post-retroperitoneal lymph node dissection, they should undergo induction chemotherapy. Post-chemotherapy relapse can be of two types. Can be early or late, based on if it occurs less than 2 years or greater than 2 years later. It is associated with a poor prognosis if the relapse is within 6 months. The treatment is usually chemotherapy with the 4 cycles of other PIP or VIP. The risk factors for a late relapse include incomplete primary post-chemotherapy surgery or presence of a teratoma in meds. The management of a post-chemotherapy late relapse is a chemotherapy with TIP or an eradication surgery. The disease seems to be resectable. Then there is another category of patients who still have a residual mass even after a salvage chemotherapy. These patients should undergo a surgical resection as far as possible, because the incidence of malignancies in such masses is very high, 38 to 53%. The incidence of teratoma is 21%, and necrosis is found in only 26% of such patients. Management of a retroperitoneal disease in a seminomatous patient. 85% of seminomatous patients have a clinical stage 1. They can be followed by 3 modalities. They can undergo either surveillance or radiotherapy or chemotherapy. Surveillance is done with a chest X-ray, a CT abdomen, and a serum tumor markers. If relapse occurs, it is most commonly occurs in the retroperitoneum and are treated with a dog-leg radiotherapy. If relapse occurs outside the retroperitoneum, it is usually treated with chemotherapy. And the risk factors for relapse are if the tumor is greater than 4 centimeters, and if there is involvement of the retitestes. Dog-leg therapy involves radiotherapy to the retroperitoneum plus the ipsilateral pelvis. The risk of relapse is less than 1%, and when it occurs most commonly in the thorax, and it is treated by chemotherapy. These patients are followed up with chest X-ray and serum tumor markers. There is no need for a CT scan. The side effects of the radiotherapy is oligospermia, cardiotoxicity, and GI toxicity. Another variant of a radiotherapy is the para-aortic radiotherapy, in which the pelvic irradiation is avoided. Advantages of para-aortic therapy is that it decreases the risk of secondary malignant neoplasms, and these patients have a better spermatogenesis as compared to patients who undergo dog-leg radiotherapy. Disadvantages are that these patients have to be followed with a CT pelvis, and there is a risk of a pelvic recurrence. Another option is a chemotherapy, where 1 or 2 cycles of carboplatin can be given to such patients. Overall, for conclusion, all patients that can be followed up, and there is less likely of such patients to be lost to follow-up, should be followed on a surveillance basis. However, patients who are likely to be lost for follow-up should either undergo a radiotherapy or should undergo 1 or 2 cycles of chemotherapy. For clinical stage 2A and 2B patients, there are 2 therapies, either a radiotherapy, including a dog-leg radiotherapy, which has a good survival rate of 92 to 100% for 2A disease and 87 to 90% of 2B disease. And if relapse, it is treated by chemotherapy. Another option is a chemotherapy, where is 3 cycles of BP or 4 cycles of EP can be given. For patients with greater than 3 centimeter retroperitoneal mass or a multiple retroperitoneal mass, chemotherapy is preferred over radiotherapy, as a risk of relapse lower than the radiotherapy. For class 2C and 3 patients, 90% of these such patients fall in the good risk category and can be given 3 cycles of BP or 4 cycles of EP and have an overall survival rate of 90%. And only 10% fall into the intermediate risk therapy group, and they can be treated with 4 cycles of BP therapy. Post-chemotherapy mass in a seminomatous patient, to evaluate it, a PET scan, FDG PET scan should be done after 6 weeks. For patients who have an FDG avid disease and a lymph node mass of greater than 3 centimeter, retroperitoneal lymph node dissection is the treatment of choice. And for patients who have a non-FDG avid mass or a mass less than 3 centimeters, they can be observed because the chances of malignancy is only 0 to 4% in such masses. For patients with the relapsed seminoma who are chemo naive, the patients such as who were on surveillance should be treated with a dog-leg radiotherapy, and who were post-radiotherapy should be given chemotherapy. In post-chemotherapy patients who relapse early, before 2 years, should be given 4 cycles of VIP, and patients who relapse late after 2 years should be given a surgical option if the disease is resectable. Otherwise, chemotherapy should be given. For patients of brain metastasis, most commonly it is associated with choriocarcinoma. The patients with metastasis to the brain should be treated with 4 cycles of BP, followed by resection of the residual masses. Patients who relapse in brain should be treated with first line of chemotherapy and then followed by resection.
Thank you, Prashasya. Nimesh, has any faculty from outside joined us? I can
No,
see. No. Okay. So thank you. Any residents and Nachiket, do you have anything to say? Good. Presentation was good, no doubt. But we need to be a little more concerned about the technical aspect also. There should not be interruptions. Or as you know, I will just try to briefly summarize and also put a few points which were probably omitted here. So as you all know, testicular tumors is the most curable solid neoplasm occurring in the relatively younger population. So it is very important, like we do a self-examination of the breast in females, it's very important to have a self-examination of the testicles in young adults so that we catch these tumors at an early stage and we can treat these patients. And we know this is the most treatable solid neoplasm with the most sensitive tumors to chemotherapy and radiotherapy. The other aspect is because this is found in younger population, cryopreservation is a very important aspect. So before even doing a radical orchidectomy, inguinal orchidectomy, you need to preserve the semen in every patient who wishes to have a family or continue his family. Then we all know seminoma and non-seminomatous. Seminoma is relatively localized. So as he has already said, 85% of the seminomas are usually stage 1 disease. And then, whereas non-seminomatous could be a higher stage disease to begin with. We also need to know something about the paraneoplastic syndrome that can occur in testicular tumors also, as we see in renal tumors. So one is kind of a hypothyroidism, which can occur in these patients. And secondly, because of that same kind of alpha subunit in these patients as with TSH plus beta SH. Secondly, there is another thing called limbic encephalitis, which can occur in some of these patients. As we have discussed, active surveillance forms a very important component to reduce the various complications of chemotherapy and radiotherapy. So we need to risk stratify these patients. So in the risk stratifications, what are the most important things? One is the histology, that is non-seminomatous or seminomatous, then whether METs are present or not, and then the tumor markers, whether the tumor markers have come to the normal level or not. And if it is a non-seminomatous, then it is very important to know about lymphovascular invasion, whether present or not, and if the embryonal carcinoma component is higher. If it is more than 40%, the risk becomes higher. So we need to risk stratify these patients so as we can treat these patients accordingly and put these patients in active surveillance if they are good risk patients. And another thing is about the retroperitoneal lymph node dissection, as we know, is indicated in patients of non-seminomatous germ cell tumors for either stage 1 or stage 2A disease. And particularly if the tumor is predominantly teratoma. If it is predominantly embryonal cell, we again go for chemotherapy rather than RPLND. So RPLND is rather more used nowadays for post-chemotherapy residual masses, right? Again, similarly, the advanced disease can be risk stratified into good, intermediate, and poor risk, depending on all those criteria that I've mentioned. And we have also discussed about relapse and refractory cases where salvage chemotherapy is usually given. Another kind of treatment is hematopoietic cell transplantation. If everything fails, then stem cell transplantation is another kind of treatment. One word about partial orchiectomy. as I said, testicular sparing surgery has come up recently. And if the tumors are very small, then definitely you can do, particularly if the other testis is already gone or it's not good, patient is infertile, then we might do a testicular sparing surgery in some of these patients. When should the biopsy be done in the contralateral testis? Patients who have risk factors like cryptorchidism, infertile patients, atrophic testis, etc., or ambiguous genitalia. All these are risk factors for developing testicular tumors, even in contralateral testis, where the biopsy should be done if when you have an ipsilateral testicular tumors. Another thing is about carcinoma in situ of the testis. So that we haven't discussed. Testicular carcinoma in situ. If we do a biopsy in these patients who are at risk, and if it comes out to be carcinoma in situ, and particularly we do a immunohistochemical staining with placental alkaline phosphatase, and it comes positive, then probably the patient has carcinoma in situ, and a local radiotherapy is useful in such patients where they would spare the Leydig cells, which is responsible for the synthesis of testosterone, and they will actually kill the germ cells. So for carcinoma in situ testis, we need to think about local radiotherapy to spare the testicles. So this was in brief the summary. If anybody has any question or any suggestion, any idea, anything you want to know? Yes, yes, Adi. Yes. So the question is, why do we hurry doing an orchiectomy in patient with testicular tumor and not in other tumors?
We do not want the disease to progress to into the retroperitoneum. And because the management of retroperitoneum is very class stage upgradation, and the management of retroperitoneum is very important, but includes chemotherapy, radiotherapy, or
Testicular tumors. These are germ cell tumors. Very, very kind of they have a very high doubling time. They would progress very soon. So definitely tumors which have high doubling time, then definitely they need to be treated as early as possible. Anybody has anything else to say? Just one thing more. Let's suppose there is a testicular mass and the patient comes, you are doubtful whether this could be a testicular mass, because we don't do a biopsy in these patients, right? Before doing a radical orchidectomy, which can increase the stage of the disease. So in that case, if it's doubtful, then we need to go ahead doing a inguinal orchiectomy. And then there is a maneuver called Shivasu's maneuver that is very important, where you put a soft clamp on the inguinal cord and then bisect the testis and see whether there is a tumor or not. If there is no tumor, again, suture the testis and do not do anything. And if there is a tumor, then you go ahead either doing a frozen section biopsy or doing a radical orchidectomy. Anything else? So thank you, everybody. Thanks all the residents and faculty for joining us today. And I thank everybody, those who might have joined us today on Zoom. And so there is something on the chat box. I'll just see. So it was just to minimize your camera view. Okay, thank you. Thank you, Gòyal, for that message. Thanks, everybody, and have a good day.